Warm welcome to one and all. Today, we are going to have a discussion on an important topic, acute kidney injury, which we will face either in a ICU, critical care unit, or post-operatively following the complex surgeries. Regarding my disclosure, I am attached to Sri Lakshmanarayana Institute of Medical Sciences, Puducherry, affiliated to Bharat Institute of Higher Education and Research. I'm not, it is not for any financial gain. For academic purpose, this talk is being delivered. Kidney, so important function of filtration and excretion of nitrogenous waste product in the body. When the filtration and excretion functions of the kidney are affected, there will be accumulation of the nitrogenous waste products and disturbances in the electrolyte balance and metabolic derangement, which leads to the decreased functioning capacity or the impairment of the kidney function, which we call now as acute kidney injury. Now, in this talk, we are going to have the definition of AKI and the impact of AKI, pathophysiology of acute kidney injury, the conceptual model of acute kidney injury progressing to the chronic renal failure, that is CKD, chronic renal disease, and which require renal replacement therapy, though in the form of the dialysis or transplant, renal transplant. And take home message. The definition of acute kidney injury. Acute kidney injury, previously called acute renal failure, denotes a sudden, often reversible reduction in kidney function as measured by the glomerular filtration rate. There are so many criteria used for defining the kidney disease, which included the renal output and glomerular filtration rate. The kidney failure was first reported following a mercury poisoning. And subsequently, in the rifle criteria, that is the risk injury failure as a risk factor, and the end-stage renal failure, end-stage loss of renal function, and end-stage renal failure as outcome measures. And then the Acute staging was used for defining the kidney injury, wherein 3 stages were taken into consideration. And then in 2012, the CADIGO, which criteria are used, which also uses staging. Acute renal failure progresses to the severity leading to the structural and functional impairment of the kidney, and ultimately total loss of kidney function. As I told, different criteria for acute kidney injuries have been documented. Refill criteria, Akin criteria, and Kedigo criteria. Refill classification shows the risk factors leading to risk, injury, and failure, and outcome measures, that is loss of kidney function and end stage kidney disease. In the glomerular filtration rate and urine output and serum creatinine are used in assessing the progress of impairment of renal function in referral classification. Risk involves increase in the serum creatinine of 1.5 times the basal or GFR, glomerular filtration rate, reduced to 25%. With urine output less than 0.5 ml per kg per hour per kg for 6 hours. Injury, increase in the serum creatinine 2 times the basal value or GFR reduction more than 50% and urine output less than 0.5 ml per kg per hour or 12 hours. It is considered as a failure when serum creatinine is 3 times the basal with the GFR reduction of more than 75%. Or serum creatinine more than 353.6 micromoles per liter, that is more than 4 milligram per deciliter per deciliter, and urine output less than 0.3 ml per kg per hour for 24 hours or anuria over 12 hours. Loss of kidney function, a complete loss of kidney function more than 4 weeks. End stage renal failure involves complete loss of kidney function for more than 3 months. Acute kidney injury network defines acute kidney injury as an abrupt reduction of kidney function within 48 hours manifested by one of the following characteristics. That's an absolute increase in the serum creatinine of 0.3 milligram per deciliter or greater. To a percentage increase in the serum creatinine of 50% or greater from the baseline. Three, serum creatinine more than 3 times, more than 3 times, or if the baseline is more than 4 milligram per deciliter, increase of 0.5 milligram per deciliter. With a urine output less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. So stage 1 involves increase in the serum creatinine of more than 0.3 milligram per deciliter, or increase in the serum creatinine 1.5 times the basin with a urine output less than 0.5 ml per kg per hour for more than 6 hours. Stage 2 involves serum creatinine more than 200 or more than 2 times the base. And stage 3, serum creatinine more than 3 times the base with the urine output of less than 0.3 ml per kg per hour for 24 hours. Total anuria 12 hours. Stage 3 also includes the patients requiring renal replacement therapy independent of the stage. Defined by serum creatinine or urine output. So this is how the rifle criteria and Acute criteria are used for the assessing the acute kidney injury and staging of the acute kidney injury. Recently, the CADIGO criteria involves kidney disease improving a global outcome. It is a independent body which works for the improvement of the health condition of the patients suffering from a progressive kidney disorder. As per CADIGO criteria, acute kidney injury is defined as any one of the following, and it is not graded. One, increase in serum creatinine by 0.3 milligram per deciliter within 24 hours. Not increase in the serum creatinine 1.5 times the baseline, which is known or presumed to have occurred within 7 days. Other criteria, one more criteria, urine volume less than 0.5 ml per kg per hour for 6 hours. Now let us know the staging of acute kidney injury. It involves estimation of serum, creatinine, and urine output. Stage 1 is 1.5 to 1.9 times the baseline, or more than 0.3 milligram per deciliter increase at any time. With urine output less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2, 2 to 2.9 times the baseline. Increase in serum creatinine with a urine output less than 0.5 ml per kg per hour for more than 12 hours. Stage 3, the serum creatinine increase 3 times the baseline value, or increase in the serum creatinine to more than 4 milligram per deciliter or initiation of a renal replacement therapy in patients less than 18 years, or a decrease in the EGFR, estimated GFR to less than 35 ml per minute per 1.73 square meter body surface area. The anuria for more than 12 hours. Acute kidney injury conceptual model. Here, the normal kidney injury, whenever the filtration mechanism is affected, progress to increased risk and to the damage. And if the factors that are responsible for causing the risk are taken care of, the kidney function may return to normal. If not, further deterioration leads to the damage, and structural damage leads to a severe reduction in the GFR, and the functional impairment progresses, which may lead to ultimately the kidney failure. The stages are defined by the creatinine and urine output or surrogate markers. And the GFR reduction will progress to more severe extent as the kidney function is the filtration mechanism is affected. That is, more and more the functional units of the kidney units of the kidney will get affected, and leading to the chronic kidney disease and ultimately death. Up to the stage of a kidney failure, the risk factor responsible for the functional impairment are taken care of. The kidney kidney impairment will reduce, and it can be reversed once the structural damage has been more affected. It leads to the end stage renal failure, and ultimately it may lead to mortality if the renal replacement therapy is not initiated at the earliest. Sometimes they will require the renal transplant. Risk factor for the acute kidney injury include sepsis, critical illness, circulatory shock, complex surgeries, cardiac surgeries, the nephrotoxic drugs, poisons. Susceptible factors include dehydration, volume depletion, advanced age, female gender, chronic kidney disease, diabetes mellitus, cancer, and anemia. Causes of the acute kidney injury includes pre-renal, renal, or interstitial, and post-renal. Pre-renal involved prior to the filtration mechanism, which will be because of the reduced perfusion. Yes. There is efferent arteriole, and efferent arteriole, which bring which are the uh, which are important for maintaining the perfusion at the glomerular filtration. When hydrostatic pressure responsible for this maintaining a pressure for filtration is affected, there will be a inadequate filtration leading to the accumulation of the waste products and the problem of the renal failure, which is called acute kidney injury. So, cardiac failure, sepsis, blood loss, dehydration, and the afferent arterial constriction or efferent arterial dilatation. Renal illness, the infection, glomerulonephritis or vasculitis, tubular necrosis, acute tubular necrosis because of the drugs or toxins, prolonged hypotension affecting the blood supply to the kidney, thereby the damage, inflammatory diseases, and infection. Post-renal involve the obstruction to the urinary flow through the ureters or from the bladder and urethra. Those urinary calculi, retroperitoneal fibrosis, prostatic enlargement or prostate cancer, cervical cancer, urethral stricture, and meatal stenosis. Pathophysiology involves a healthy kidney following the tubular injury or the tubular obstruction, increased pressure leads to the injured kidney. Injured kidney leads to the scarring and the macrophages infiltration, resolution. There can be a resolution of the inflammatory cells at the tubular proliferation, and if the endothelial repair and the repair mechanism is taken care of, the kidney may have a scarring and ultimately lead to the this scarred kidney or total damage of the kidney. So depending on the time duration, the course of the kidney disease can be graded as acute kidney injury when it occurs within 7 days with the increase in serum creatinine by 50% within 7 days, or increase the serum creatinine by 0.3 milligram per deciliter within 2 days or 48 hours, oliguria for more than 6 hours. There is no structural damage. If this progresses for more than 3 months, the patient may develop acute kidney disease. Disease means there is an impairment of the structural damage. GFR less than 60 ml per minute per 1.73 square meter body surface area, or increase the serum creatinine by more than 50%. Here, there will be a structural damage leading to albuminuria. Depending upon the involvement, there can be the albuminuria, hematuria, and if it progresses to more than 3 months, GFR less than 60 ml per minute per 1.73 square meter body surface area, a severe kidney damage leading to albuminuria will be a presenting feature. If the GFR is more than 60 ml per minute per 1.73 square meter body surface area, there will not be any kidney damage. So it takes into consideration, this takes into consideration GFR, whether it is less than 60 ml per minute per 7.3 square meter surface area, or more than 60 ml per minute. If it is less than 60, marked kidney damage, there will be marked kidney damage. If it is more than 60 ml, there will be no kidney damage. So if normal kidney disease or CKD may progress to acute kidney disease or acute kidney injury. with normal GFR and normal functional reserve, normal GFR, reduced functional reserve, reduced GFR, incidental CKD, CKD with maintenance of CFR, progression to CKD.